So, good afternoon, everyone. Welcome to the EDTNA ERCA webinar. My name is Ilaria de Barbieri. I'm the Scientific Board Chair of EDTNA ERCA, and I'm very pleased to welcome all of you to this webinar. And today I'm very honored to introduce Professor Walter Sermeus. Walter is a professor of healthcare management, Leuven Instituut voor Healthcare Policy, University of Leuven in Belgium. He is program director of the Master in Healthcare Policy and Management and head of the Q Leuven WHO Collaboration Center on Human Resources in Health Research and Policy. Walter is also Senior Fellow in the Center for Health Outcomes and Policy Research at the University of Pennsylvania in the USA, Fellow of the European Academy of Nursing Science, the American Academy of Nursing, the Belgian Royal Academy of Medicine, the Royal Society of Medicine UK, and the Accademia Europaea. And last but not least, he is the European coordinator for the Registered Nurse Forecast Network. I suggest to all participants to go and see this fantastic publication on nurse staffing across Europe. And so, Walter, I'm very honored to have you now on board. And so, dear audience, please feel free to ask as many questions as possible using the chat box. And after the presentation, we will open the Q&A session, and Professor Sermeus could answer to your question. So, Walter, please, I'm passing the mic now to you.
Thank you very much, Ilaria. So I'm very pleased with this webinar to give, and the webinar is on nurse hospital staffing. So what can we learn from the recent crisis we are in right now on COVID-19? And I try to be as much up to date as possible. So I went to the recent data of today so that we have a complete picture where we are all over Europe. So what I would like to talk with you is the current situation on COVID-19 in European hospitals, and what are the strategies that hospitals and countries are following, mainly about infrastructure, but mainly about workforce, because that's the main focus of the talk. And then I will have some discussions and recommendations following our studies, what we have been doing. So Dr. De Barbieri was also talking about the RM forecast study. So we have some recommendations out of our research for the situation we are now in Europe. Just to give you an overview of the cases, and it's the number of cases we have within Europe. It's a larger Europe, so it's Europe plus Norway, Switzerland, Iceland, some of these countries that we are seeing in the European Economic Area. As it is today, you see two peaks. One peak was the peak of March, the first wave, and we had the second peak right now in the fall of 2020. And you see that the current peak is much higher than the first peak. So it doesn't mean that we have the same impact on our hospitals, but we have certainly more cases at this peak than we had before. Just to give you an overall idea of the number of cases in Europe, and these countries, we have about 10 million cases reported so far, and we have about 250,000 people that died of COVID since the starting of the crisis in the beginning of the year. Here you see some overview all over Europe, and so you see the number of cases per week per 100,000 inhabitants, and you see that we have some cases all over Europe. So you don't see the cases over here in Switzerland because they were not reported here, but you see in most of the countries we are with a large number of cases, giving the color. The color is only a little bit less dark in the northern countries. So we see some less cases in Finland, in Estonia, in Norway, but we have also a lot of cases in Sweden. So cases are a little bit lower in Iceland. So these countries are a little bit more under control. And we see also some little bit of lower cases in Germany. But most of the countries have very high cases, and the cases are what we see over here is more than 250 cases per 100,000 inhabitants. These 250 is a kind of critical threshold, but some of these countries are way above this threshold. Just mentioning countries like Belgium or Czechoslovakia, the Czech Republic, I have to say, so they have cases above 1,000 cases per 100,000 inhabitants. So this is much more than what you see on this picture alone. So when we are talking in this presentation, we will mainly focus on hospital admissions and the impact. Of course, it's a whole trajectory. And so going upstream, so what of course is quite important that we are trying to prevent to get infected. So we know all the measures you have to take. You have to take measures of social distance, mouth mask, hand hygiene, ventilation, and so on. It's important that we do some screening, contact tracing, put people into quarantine, and so on. So that's what we know. And still, when we are talking about 10 million people are affected or infected in Europe at this moment in time, it means that these 10,000 people are just 2% of all people in Europe. And so it means that 98% of all people living in Europe are still uninfected or unaffected with COVID. But out of these 2% that were infected, of course, most of them just have mild or moderate impact or effects. It's for 80% of them. Some of these infections are asymptomatic. Sometimes they are symptomatic and have some fever or some cold, or don't have some problems in tasting and so on, in hearing, has some headaches problems, but they are quite mild and moderate. And what we see is that about 90%, 19% of the patients are admitted into hospitals. Most of them are treated quite well, just giving oxygen and so on. But there are 5% of these patients that are very critical and are admitted into intensive care units. And what we see is that the case fatality rate is about 2.3%, that people that are dying out of the disease. So most of these people, when you are infected, are doing quite well and stay at home and are not admitted into hospital. It's about less than 20% that are admitted in the hospital, and only 5% get into ICU admission. And I really want to focus on this group of patients. So of course, that's the patients that are threatening our healthcare system and that are threatening our hospital systems. And so this is the main focus. You understand that the prevention and all the treatment before is of course quite important. If we could prevent of people in getting ill, of course we don't need the capacity for treating these patients. So it's important that we do these preventive measurements, and that we are doing this screening. So this is quite important for surviving or letting the system survive. But of course we have to treat these patients in our hospitals. And so here you see some overview of patients into the hospitals. And so these are data from Worldometer, that it's a database, an international database that giving the figures day by day. And you see some large differences from country to country when we are talking about patients admitted into these intensive care units. So it's about these 5% of patients. And you see that some countries are more severely hit, like Belgium or like Czech Republic. We see also some cases, some severe cases in Slovenia. We see some cases in France, in Spain, and so on, in some other countries as well. And then again, what we see, the same countries where you have less cases, you see also less hospital admissions and less ICU admissions. It's mainly in the northern countries where you see this lower number of cases. So, but you see large differences from 0.23% of cases up to more than 12% 12 cases per 100,000 of population. Altogether today, more than 28,000 patients were admitted in these ICUs all over Europe. So it's a large number of patients that are in our intensive care units. I brought a few pictures and a few graphs of some countries, and just to discuss some of these issues. So the first picture you see are two countries, is Belgium and Czech Republic. So these are the countries that are most severely hit at this moment in time. And so you see that in Belgium we have about 12 ICU COVID patients per 100,000 population. In Czech Republic it's a little bit less, but still quite high, 11 out of 100,000. But what is important to understand, if we are capable to deal with these patients, is ICU capacity. And the ICU capacity in these both countries is quite large. So we have a capacity about 16 beds per 100,000 population in Belgium. We have more than the double of this capacity in Czech Republic. And it means that bed capacity in intensive care is quite high for these patients in Belgium, and really threatening the hospital system. In Czech, it's also quite high, but it's still under control. So they still are able to manage that system a little bit more because they have more capacity available. So it's a capacity that is also driving the system. And so we see some large differences in capacity from country to country. We see it's in some countries it's less than 10 beds. Then we have most of these countries are between 10 and 20 beds, but you have some countries like Germany, like Czech Republic, where we have more than 30 beds, intensive care beds available to taking care of these patients. Here you see some overview of countries that are getting into problems right now. So you see there was a big peak, high peak in March, April, and so now they are peaking again, and also ICU is peaking again. And so this is the case in Italy. So what we learn from Italy is that the occupancy of ICU beds is going way beyond 30%. And what we see is that 30% is a kind of critical threshold. So what we see, if we have more than 30% COVID patients on ICU, it's really threatening the hospital because it has some influence on other patients as well. So it means that that our capacity is getting much lower over there, and we see some capacity problems going on. And we see also that the distribution in the country is also getting more difficult. The same thing what we see for this moment in Italy. We see some problems in some parts of the country. We see some problems in the south, in the region of Naples and Rome at this moment in time. We see some problems in the north, when we're looking to Piemonte, Lombardia, and so on. So in really some parts of the countries, we see already some problems in dealing with COVID admissions at ICU. Same thing is going on in France. So the capacity is quite on the average of Europe, and you see that already the number of COVID patients in ICU is quite high. And many countries are getting into that phase. So I put a number of countries below. You see Austria, you see Croatia, you see Greece, Hungary, Netherlands, Poland, Portugal, Slovenia, Spain, Switzerland. All these countries are already above that threshold of 30% beds that are occupied by COVID patients. So they are really threatened in their system. Here you see some countries that are doing much better. So you see some countries like Finland and Denmark over here. You see that the capacity of intensive care is quite low, but at the same time you see that the number of COVID patients on the ICU wards are also quite low and below 1 bed per 100,000 population. And you see that, for example, for these countries, 4% or 8% of these patients are COVID patients, and so they are reasonably under control. So it means that they are under 10% ICU occupation for COVID patients. We see similar data in Estonia, Iceland, and Norway. So these are more the northern countries. It's very difficult to compare why some some countries are more hit than other countries. So when I talk to the biostatisticians or the epidemiologists, you're saying it's probably related to the density of the country. It's probably related to mobility figures. So I think much of what we see in the data right now, certainly in the second wave, it has to do with holiday and summer holiday mobility. So we know that many people went to the southern countries for holidays. So that's what you see. We see same thing happened in Czech Republic, where a lot of people were visiting some of these major cities like Prague. We see the same thing happening in Switzerland, in Geneva, where the rates were also going up. And the same thing is happening, of course, in France, is happening in Italy, is happening in Spain. So we see that mobility is quite an important element. Of course, the timing of the lockdown is also probably quite important. And we see that many of these countries that are really having trouble are introducing lockdown measures, but they are introduced at different time frames and so on. And we see also the effect of these lockdown measures. So also when I'm looking to my own country, Belgium, we see the numbers going down right now, not only in the number of cases, but also in the number of hospital admissions and ICU admissions. And it's probably related, it's very lot related to the time of the lockdown. We see that, for example, Ireland was introducing a lockdown quite early, and we see that it has some effect on lower impact on hospital admissions. So it's a whole chain of decisions you have to understand and you have to look for. But it's important to know that some countries are really threatened by many patients and many hospital admissions and many ICU admissions, and I expect some other countries to follow. What we think is that some countries like Finland and Denmark, as a few examples, are keeping the system quite well under control. They did in fact also in the first wave. So also when you look at the numbers over here, it are quite low numbers in comparison with the rest of Europe. So what I would like to talk with you is about strategies. What are the strategies of different countries in dealing with infrastructure and workforce? How we can contain these crises. And so I was mainly looking to hospital infrastructure, so not to prevention, not to early treatment, testing, and so on. So I was not looking into that, but was mainly looking to hospital infrastructure decisions that have been taken in Europe, in European countries, and then mainly these workforce issues all over Europe. And so I crossed the countries I've been looking for. Some countries I didn't look at, so I mainly looked to EU countries and the extension of these countries, the EEA countries. So about 32 countries I was looking at. So the countries I was looking at was particularly to the documents that were available on the Health System Response Monitor. And it's from the European Observatory on Health Systems and Policy. So you know it's an initiative by the WHO Europe. And so they are providing this type of data, and these are monitoring the intervention in the different countries day by day. So it's a quite important resource to look at. The first thing I want to look at is on strategies on hospital infrastructure. And so what we see is that what most countries did was mainly focusing on increasing hospital capacity, mainly for COVID patients. And so how to create enough capacity for these patients. So of course there are quite a lot of differences from country to country. Some countries have more capacity available than other countries, but there are some strategies that countries have been following. First activity and initiative was by stopping all non-urgent elective treatments in hospitals. And that was the main strategy in the first wave. So what we saw in the second wave is that many countries try to keep their elective treatments in hospitals, because we were seeing that patients were postponing some hospital visits, and by postponing, they were also getting into problems. They had some complications in waiting. Some people were even dying because they are on waiting lists and so on. So we try to keep it. But what you understand is when the numbers are going up, it's quite difficult to keep this kind of activity open. So, and it means when your hospital capacity is going above 50% and ICU capacity is going beyond 30%, is quite difficult to keep these non-urgent elective treatments and admissions open for other patients, and that's what we certainly see. The second thing is that a lot of hospitals, like Poland did that, Turkey did that, were creating hospitals dedicated on COVID-19. So it means that not all hospitals were COVID hospitals, but that some hospitals were really dedicated as COVID-19 hospitals, in which all cases were concentrated. And it means that by doing so, some more capacity was created in a more efficient way. Some countries were creating some field hospitals, using the military and so on. So it were temporary kind of capacity that were used in some instances. Sometimes you saw some hospital capacity from private sector that came public, some rehabilitation centers that were transformed into COVID centers, military hospitals and so on that were also used as kind of COVID centers. And then some special things like what we saw, for example, in France or Spain, also trains were completely introduced and organized as COVID trains and COVID kind of capacity. So we have in France, we had some special capacity in bringing patients from one region to another region, and some high-speed COVID trains. In Spain, it was more that some trains were used as a kind of additional capacity. So within the hospital, so the first thing what we have been doing was creating some hospital capacity by just taking this non-urgent activity out of the hospital so that we have more room available. But at the same time, certainly for ICU, we are creating some additional ICU capacity in recovery rooms, operating theaters, and so on. What is quite important there is the number of ventilators. So ventilator capacity was a major focus. And what we saw is that in most of the countries, there was not a shortage of ventilators. And there were only a few countries that were struggling with that. But most of the countries has enough ventilators available because they were made available from other types of units like operating theaters and recovery rooms. At the same time, many countries were also investing in medium care units, isolation units, in providing high levels or high doses of oxygen. And so they were transforming these units in what they called high flow nasal oxygen units, HFNO units. Also Belgium at this moment in time. So we are really struggling to have enough of ICU beds available for COVID patients. And so we are creating about 500 of these type of medium care type of units, which are able to give high levels of oxygen. Because that's for some patients, this is enough for the treatment. And so now they are on intensive care. And so when we have this kind of capacity, we can move them out of intensive care and make these intensive care beds available for ventilated patients. But what was the real struggle, and certainly in the first wave, was not the number of ventilators, but the number of personal protective equipment, surgical masks, gloves, gowns, alcohol gel, this kind of thing. And I think every country was struggling with that. So it means there was a shortage of this kind of equipment. Most of the equipment was produced in China. China was also in kind of isolation because of COVID. All the world was really looking and making some, was buying this kind of equipment in China. And so what we saw is that many countries became self-supporting. And so where industries in the country were reallocated, were changing, were making these things themselves. And I think I don't hear these kind of problems anymore in the second wave. So I think most of these problems on infrastructure and on equipment have solved. So this is a good thing. So I still see some problems in some medication that is not available in some countries, and there are some shortages over there. But I think PPE is quite, most of the time it's available, and I think we have the best material for healthcare workers. Most of the strategies are on workforce, and I think it's the main shortage and is the main resource. So I don't see so many issues on infrastructure. I think we can make the capacity, but it's not enough to have capacity. It's important to have enough workforce, and workforce is a critical mass, is a critical indicator, is a critical resource we have to deal with. And so we see a lot of differences in resources from country to country. We see that countries are starting in complete different circumstances. And you see on this graph, you see the number of doctors per 100,000 per thousand of population on the horizontal axis. You see the number of nurses per thousand population on the vertical axis. You see the average of the EU. The EU means that we have 3.6 doctors per 1,000 of population, and we see 8.5 nurses per 1,000 of population. But we see large differences, and we see some countries that are high in doctors and nurses, for example, Norway on the top. You see some countries that are high on doctors and low on nurses. For example, the most on the right is L. It's Hellas, is Greece. You see Austria, you see Portugal over there. And then you see on the left side, you see low on doctors and nurses, and low on, for example, Poland or Romania or the UK or Latvia. And then you see some low on doctors and high on nurses, for example, Belgium. And I think this situation is quite important to understand. So we see that some countries that are on the left side and on the downside, so it means low on doctors, low on nurses, have some real struggle. So it means that the capacity is getting lower. They might have the ICU beds, but they don't have the ICU nurses to take care of these patients. And so they focus more on retraining and so on. So that there is a really need for a critical mass for this type of countries. And so they are in trouble because their starting position is much more difficult than it is for other countries. Yeah. Let's look to some of these measures that the different countries has been taken. And looking to the whole list of strategies, there were 3 or 4 strategies that I identified. So there is certainly a strategy to increase capacity for qualified workforce. So this is an important thing. So we need more people to take care of these COVID patients, and of course it's quite critical to do so because it has to do with training and competences. Then of course we have to take some supportive measures, and then there are some psychosocial measures as well. So what our countries have been doing, what we see in most of these countries is a lot of training courses. Training courses in training people for ICU, training for respiratory management, training for infection control. And it's mainly so that these nurses that are trained are working under supervision of nurses that have a qualification on ICU or intensive care nursing or dealing with this type of patients. So it's really helping them to understand how to treat for these patients. We see some countries that they have been changing the contract from part-time work to full-time work to have more of these competences available. I see that in some countries they have increased the maximum working hours. So you normally work 38 hours a week, but up to 60 hours a week, 12 hours a day. I think it's a risky thing to do so because people are getting more fatigue, and so it's risky to really make people work more. So I will come to that in a minute. Some countries have been easing mutual recognition of foreign trained health professionals, people that are trained in other countries but are not allowed to work in another country because their diploma was not recognized, and so they were easing in doing so. Some countries have really worked with a kind of medical care reserve, mainly for students. So it means that the last year students, it means medical residents, they have been refocused working on COVID patients now. And also retirees were asked to come back and work beyond the age of 65 up to 70. They have created a lot of support shops, asking for volunteers. Just looking to the data of the UK, more than 600,000 people were available or willing to help in the healthcare system. So it's a large amount of people, and they can all do all kinds of things that that are done by nurses before. So they can take care of meals, they can take care of transport, they can take care of communication with patients, they can sit with patients and so on. They can do all these necessary things that were done by nurses before. And then, so we see some measures in easing legislation, more flexibility. For example, what we see that are strict nurse staffing levels in ICU for nurses. What we see, so it's in 1 nurse for 2 patients. What we see that these nurse staffing levels were getting a little bit lower, 1 in 2.5 or 1 in 3.5 and so on. I think it's also, again, it's risky. So because there is a lot of competences required, and I think the staffing levels are there to keep patients safe. So we see some risks over there. I think that some nursing activities that were restricted to nurses are widening in some countries to non-nurses. So to allowing non-nurses to do some nursing tasks. It's mainly in taking some hygiene and some this kind of daily care activities. So I think that's not a real problem, but the real problem is when it goes into taking vital signs, into giving medication and so on. So there may also be some risk in some countries, but it's by creating more capacity, and that's what many countries have been doing. And I think more flexibility, there is always a risk. So I think what is quite good is trying to involve more people, but it's not so easy to do that. So it's really trying to invite and recruit more people. And we see many countries, we see some additional activities, including recruiting people for healthcare kind of professions. The second thing what we see is that that a lot of countries take some supportive measures. So for example, what we see, if you are easing the way that people come into the healthcare system, at the same time, some countries are taking measures about the conditions which caregivers are allowed to take care of COVID-19 patients. For example, in Denmark, they say, people come in, you can recruit new people, but it means when you're 65 plus, it means that you're also at risk. And so we don't allow people above 65 to take care of COVID-19 patients. So they can take care of other patients, but not COVID-19 patients. It means nurses with chronic conditions at the same thing, they can take care of other patients, but not COVID-19 patients. Pregnant nurses, doctors or patients, nurses that are compromised in their immune systems. So when there are some problems, and there's some countries take some restrictions and not to take these healthcare providers to these COVID-19 patients. And I think it's a wise idea, because there are some final risks, and we come to the risks in a minute. Some countries take some measures of taking COVID-19 as a disease, as an occupational disease, as a real risk of being a healthcare provider. And I think it's a real risk seeing the figures. I will show you some figures. Some countries have already some figures about how nurses and doctors are affected by COVID, and I think they are very high figures. And so we have to really take care of our healthcare providers in a sensible way. Of course, when people are working more, 60 hours a week, working more full-time and so on, so a lot of countries are providing some support. For example, to provide childcare. We know that these young nurses and doctors cannot bring their children to their grandparents because they are probably at risk as well. So what we see is that some communities and some municipalities are taking care for the child as well. Then, of course, what is important, that was really an issue at the first wave. I think all healthcare personnel need to take care all kinds of protective measures. So there need to be enough material available. They have to be tested regularly. I see some systems are testing healthcare providers every week, every month. They take some quarantine measures or isolation measures when you have been in contact with a patient, when you were not protected, and so on. So there are some. It's important to take care of people that might be getting infected. And at the same time, what we see is that there is a lot of absence because of this quarantine of self-isolation. So we see that more people are getting sick, of nurses and doctors, but not only getting sick, but there is also some self-isolation because they have some sick people in their families and they're taking out of they are allowed not to work at that moment in time. And we see that what we see that it's that normal absence for sickness is about 5 to 6%, but in some cases it's going up to 10%. In some cases it's going up to some 20%. And then what we see, many countries are taking some financial measures. So they give some financial bonuses for nurses and doctors because they have been taking care of COVID patients. We see some salary increases in many countries going from 5 to 10% up to 20, 30%. We see some recreation bonus. Lithuania is a quite interesting country to see. So they give some bonus to take some time off to visit some musea, to go to spas and so on, to really have some recreation when the COVID crisis would be over. So there is some bonus, some fee available for them. And psychological support, I think it's important that some psychological support is important, and so it means that there are some help desks available with some psychologists. I see that many organizations, nursing organizations, medical organizations are organizing this type of thing, so that really these people can call and have some help to take care of their health, and so mainly mental health. When they are affected, because it's quite stressful to deal with COVID patients, and so the stress means that you have should be able to really discuss it, how to cope with it, and so on. And just to give you two examples of the need for this psychological support and what comes out of it from Belgium to start with. So this is an initiative that we took in Belgium to really have some interview with healthcare providers. So it's our mainly nurses and doctors, but also other healthcare providers. We did it before COVID, or we didn't, not before COVID, but we asked them what their situation was before COVID, and then we asked them it's again in April, May, June, and we asked about some emotional reactions, unhappy, how their concentration was disturbed, did they have some flashbacks, what is the impact on the regular life, do they feel anxiety, are they able to relax, what is about their sleep, fatigue, stress, and people are alert, and so on. We ask them to score it on a score from 0 to 10, and so what you see over here is a number, percentage of people that were scoring 7 or high, and so it means high stress on these reactions. And so just to give you an idea, when we start on the right side, people alert, the red box, it's in April, so it's on the top of the crisis in April, and so it means that 60-70% of nurses and doctors were dealing with people alert, with stress, with fatigue, and so on. So it's really a real problem for many healthcare providers in different type of settings. The star is October, and it's October. In the beginning of October, it's before the second wave, in fact, and it's already very high. So we expect that this figure is much higher now, and that people are not going back to their normal reactions and normal behavior. So it's really a need to support these people giving these stress reactors. Next slide are some data from Germany. So what you see is that a lot of people in Germany, more than 11,000 people, where healthcare workers were infected with COVID-19, mainly doctors and nurses, but also social workers. 19 people died from COVID. In Ireland, similar thing, 7 people died. But what we see is that 1/3 of the COVID infections were healthcare workers. So it means that it's really a risk to work in healthcare, because many people are affected. And we see out of these healthcare workers, it was mainly nurses. And so 1 out of 10 of these people that were infected were nurses. So it's a single largest group among infected healthcare workers. So it's a real risk, and so it means that we have to really take care of our people. And so it's providing protective measures, but at the same time also recognize this kind of disease as an occupational disease, but really creating everything what we can do to support our nurses and our healthcare providers. It's an important thing to do. And so that's make me all when I see the measures that they were increasing flexibility, that they were increasing to the number of hours you can work and so on. It's in fact increasing the risk, and it's increasing the contact hours with this type of patients. So it's really a risk that we are taking. Just to look to the survey of the Irish nurses and midwives organization, and so they were surveying nurses that were recovering from COVID-19. What we see is that these nurses are still experiencing a lot of mental health difficulties, headaches, breathing problems, and so on, post-viral fatigue, and so on. So they really have problems. And so it's not because you are not admitted to a hospital and not have been really sick. It might be that you are asymptomatic or symptomatic or have minor problems, and so the issues are moderate or mild, but it still see that, so the long-term effects are still going on, and so they are still struggling with it months after they have had the COVID situation. So again, so know that COVID is a really severe disease. Even if you have mild infection, it can take for a very long time, and I think we are mainly at risk. So it's not only mental health problems, but it's at the same time also physical problems. So just going to the evidence, and it's giving some perceptions or some recommendations from what we know, and looking to the data and to the strategies we see in many countries. And so you see the different elements. So one of the elements is nurse staffing. So I'm a little bit concerned when we are dealing with getting more flexible staffing levels in some countries, so that we are saying, because we have some COVID and we have some real problems, a nurse can take more than 2 patients, they can take care of more patients. What we know about COVID is that it takes additional staff to take care of our COVID patients. So our estimate here in Belgium is that it takes 1.6 more nurses than to take for other type of patients. So it's not less nurses, it's in fact more nurses. So we have to take care of our nurses well. The same thing, it's about qualification levels. I'm not concerned. So in the training, I think it's quite important to train people, but it's not by giving a few hours of training that people are really able to take care of these complex patients. Practice environment is quite important, is how we are supporting our nurses. So it's really taking care of our nurses. It's a quite important thing, and it has some impact on the final results. When I'm looking to the outcomes, so what we see is that staffing levels and practice environments has some impact on patient outcomes and on job outcomes at the same time. And so job outcomes means mental health, how people are feeling, how people are supported. It's really on job satisfaction, it's on burnout and so on. And at the same time, patient outcomes are on real clinical outcomes. Mortality it's a first focus, but there are some other focuses as well. And so what is really the most important thing that is driving the whole wheel is the scope of practice, what nurses are doing. It's mainly about missed care, so the things that nurses are not doing. And we see if staffing levels are going lower, if qualification levels are going lower, I think what we see is that missed care is going up, and it's really driving the final results of our healthcare system. So just to give you some idea about that staffing level, so we have some idea about the staffing levels in healthcare, and if you push back on the button now, then we see some overview of different countries, and we see some countries in red, like Germany, Spain, Poland, also Belgium, Greece, and so on. we see that the levels of nursing, when we really look to medical surgical units, so no ICU units, but medical surgical units in hospitals, we see one nurse for so many patients. So for example, in Belgium, one nurse for 11 patients. In Germany, one nurse for 13 patients. In Spain, one nurse for 12 patients. We see that there is already some chronic understaffing. If you compare it with some other countries, on the green side, on the left side, for example, Norway, one nurse for 5 patients. So there is some chronic understaffing on the right side. And I think, so when we have more patients and more ICU patients, we are really stressing our healthcare system. So I think our healthcare system might be a little bit in danger. And so what I see is that a lot of countries are really understanding that they have chronic nurse understaffing, and really are moving from the right side to the left side. So I see, for example, in the UK, I see some strategies now to really deal with these chronic nurse understaffing and what we have to do about that. You see same things going on in Belgium, see some things going on in some other countries as well. So I see really understanding that this might be some critical situations in many countries that are not guaranteeing them that we are really dealing with this kind of pandemics. So it's COVID now, but it might be other pandemics in the future. Skill mix is quite important. And so what you see over here is a relationship between numbers and staffing levels going low to on the left side and high on the right side. And we see when the staffing levels are going higher, then what we see is that mortality is going down for the blue line. And the blue line is the number of nurses. So it means if you increase the number of nurses, what you will see is that mortality is going down. That's a good thing. But the orange line is the number of nursing assistants. And we see when you increase the number of nursing assistants, that also mortality is going down, what is quite good. But when you're increasing more the number of nursing assistants, then you will see that the number of mortality is going up. And what is happening here is that when you are increasing the number of nursing assistants, what is probably happening is that the nursing assistants are helping these nurses to do their job properly. And so that means that these nurses can focus on the essential things and are doing more for these patients, what is probably the necessary thing to do. So this is a good thing to do. But when you have more nursing assistants, what we probably see is that these nursing assistants are taking over the job of nurses. That's, of course, a dangerous thing. And again, with COVID, that's what we see at the same time. So what we see is that people are saying we need more hands on the bed. And it means that they are asking for more people to join healthcare, and they do whatever they can. And so it means we are asking for more voluntary people, more voluntary staff, non-trained staff, and so on, to help into healthcare, because we need more hands. And I think for COVID patients, it's probably not what we need. We need more competent and trained hands. We need people that are competent for doing the job. And so when they are helping nurses to do their job properly in taking care of COVID patients, I think this is fine. When they do things instead of that being helping nurses, but taking over the job of nurses, this might be a dangerous thing. So be aware of that. And I think we have to maybe manage the situation quite well. Good working environments. What is working environments? I think it's leadership. It's the nurse to physicians relationships, how they work together. It's the involvement of nurses in hospital affairs. It's investment in quality. It's perceptions of having enough staff available. And involvement in hospitals affairs is a quite important one. What we see is certainly in COVID, I think at the same time we have to improvise. We have to be creative in taking care of patients. And I see that nurses that are working in daily practice and dealing with these patients, they know what to do. They know what are the best measures to take for these patients, and they know how to improve patient care. And I think their voice should be heard by these executives and by the management. And I think they should be involved in dealing with these patients. And so when this is not the case, so when you see some disconnection between management and the nursing workforce, this might be problematic. What I show here is a table. It's the result of a study of Dr. Linda Aiken, with person we work with for our study in general forecast. These are American data, but you see at the mean, so it's the mean numbers on staffing and the mean effect on working environment. So it means a normal working environment. Then you see some effects of staffing on mortality and on failure to rescue. Failure to rescue is dealing with complications. And so are you able, when a patient has complication, for example, a cardiac arrest, to rescue that patient? So what we see is if you have more staff, you are able to rescue more patients when they have complication. So that's the idea of that figure. So there is a combination, a risk, an effect of about 4%, what you see. But what you see is that when the working environment is improving, what is called here 1 standard deviation above the mean or 2 standard deviations above the mean. So when working environment is really improving, what we see is that the staffing effect become larger. We see that staffing have a larger effect. When the working environment, and it means low leadership, doctors and nurses not going alone, no involvement in hospital affairs, this kind of thing. So when they are lower than the mean, we don't see any effect on staffing anymore. And what does it mean is that staffing, increasing the number of nurses, doesn't have an effect on quality and mortality rates anymore. And that's what we understand from daily practice. So you can imagine 1 nurse more for taking care of a patient. If there is no connection and nurses and doctors are not working well, this is not solving the problem. What you have to solve the problem is a connection between doctors and nurses. It's a teamwork. It's much more important. And I think the teamwork is quite important in COVID. And what we saw in COVID is that COVID is bringing teams together. It's working, is improving connections with nurses and physicians. It's really improving in giving nurses a voice in hospital management. And I hope that we can keep this. So what I see is that the crisis is really helping nurses and also doctors to be more involved in the daily management of hospitals. So I hope we can keep this. And so often I hear, of course, the message, these COVID things, COVID crisis, it's really difficult and it's really putting into problems. But at the same time, what we like is the teamwork, and it's a commitment as a team in working for this type of patients. So what we see, this is what is important, and we have to keep this for further work when we are investing in healthcare for the future. Just to come to a conclusion, and then we have some time for some questions and some discussion. I think that COVID-19 is really testing our healthcare systems, because it's really bringing everything up to the limit, and we see what is working and it's not working. At the same time, you see that the capacity of our healthcare system is not a limiting factor. The real limiting factor is nursing workforce, having enough nurses available to take care of our patients. And it's mainly specialized nursing workforce, dealing with ICU patients, dealing with patients that have some ventilation problems, ventilation issues, oxygen needs. It's dealing with some patients that have some infection problems and so on. So it's dealing with specialized workforce, dealing with this type of patients. And I think the situation in many countries is that they were already understaffed at the beginning of the crisis because there was some cutting budget. The budget was cut for healthcare in many countries. So they thought they could do it with less and have same type of quality. And we see a lot of organization was to reduce the numbers. And what we see is that the reduction of numbers has some impact on quality of care, not only for patients, but also the staff who's working there. And so at this moment in time, we also want to keep people into healthcare. I think we have to make sure that we take care of our people. And so what we should do is invest in more people, more qualifications, invest in training, what is quite important, and invest in good working environments. And so good working environments is not only providing childcare, of taking care of good teamwork and so on, but it's really creating the environment that people can do their work properly, that they really can be a good doctor or can be a good nurse. And so that is requiring good leadership, it's requiring good teamwork and good collaboration. It's requiring that they are involved in management decisions at the hospital level. So this is important. And of course, we have to steer on it. And so it means that we have to measure patient outcomes, job outcomes. Data will be quite important. I was quite struck by the fact that we know quite exactly here in Europe the number of cases, COVID cases day by day. We know the number of ICU admissions day by day. We know the number of people dying day by day, but we don't have any idea about the number of nurses taking care of patients. We don't have any idea about the number of specialized nurses taking care of these patients. In fact, we don't have just a general idea about the capacities available for ICU and hospitals. So I think the capacity problem, the workforce problem, is certainly under documented. So I think we need more of this type of data to really make the connections. So this is important to do. So I think it's really helping us, this COVID situation, to really invest in the future. And investing in the future is creating a healthcare system that is probably more resilient to this kind of pandemics. And so it means that we have to really think and build already to have a better situation to start at the beginning. I think so. In March, so it came quite suddenly. So COVID was really striking us unexpectedly. But at the moment in time for the second wave, it's not the case anymore. So we really could be better prepared, I think. And still, I see many countries are still really struggling and are in problems. So we have to avoid that in the future. So thank you very much. I have a next slide just to thank you, and then we can have some time for some discussions and questions. Thank you.
Okay, thank you, Walter. Thank you very much for your amazing presentation. And you raised so many points, and I hope that that participants will write some questions. And I have some, but maybe not questions, but some points. I took notes and I have some points for you. And it's many years that we are speaking about the shortage of nurses, about understaffing. So it's quite an old problem. But where is the core problem? Because it's a problem of recruitment, it's a problem of attraction, it's a problem of financial investment, as you said, that maybe the governments do not invest in healthcare. So from your experience, Walter, what is, well, not the problem, of course, but what could be the main problem? Why we do not have nurses?
It's a good question. So I think that we are, so that's what we learned from RM forecast, is that there is certainly in Europe the main understaffing issue. And I think giving the understaffing, I think the nursing profession is not attractive to many young people. And so people get away from the job, or people are not attracted by the job. And it will be worse in the future because of demographics. So we will get less people might be interested in becoming a nurse in the future. I think the main issue is working conditions. So this is the main issue. what we learned from the United States, and it's mainly the California case 20 years ago when they introduced their mandated optimized nurse staffing ratios that were much better than we have in most of the countries in Europe. What we saw is that when you have less patients per nurse, and so it means that you have the feeling that you have control over your job, you can do your job properly. What we saw is that, of course, these more nurses were required. And a lot of people in California were saying, yeah, so we need 5,000 nurses more. Where will we get them? Of course, because there are no nurses. What we saw is that people that were stopped being in working in the profession were re-entering in the profession because they were saying, I think this is feasible. I think this is probably the better thing to do. We saw that people that are working on the East Coast in New York were moving to California to work over there because they were saying the conditions were much better. And what we saw is that it has a very positive impact on recruitment. We saw that more people were interested in the job. And we all know, when you have been in practice, that being a nurse is the most fantastic job you can do. Yeah, it's a fantastic job because you are dealing with innovation, you are dealing with technology, and at the same time you're dealing with people. So it's the most rewarding job you can do. It's an essential job, but the conditions are not what they have to be. So I think if you're improving the working conditions, I think we will have much more people. And it brings us to the second issue, is budget constraints. And I think the most important constraint is the budget constraint. But what we learn in what is happening in many countries, and I'm following a project now in Ireland, where they are stabilizing nursing wards. So stabilizing means that you are saying, what is the workload? And so according to the workload, how many nurses do we need? What are the qualification levels do we need? And can we improve this working environment? So it's a stabilizing type of mechanism. So it means more nurses if you need more nurses and so on. And if they do that, they have less agency nurses. What we see is that sickness absence is going down. They have less burnout. But at the same time, complication rates are going down. People length of stays getting shorter. And so they did an economic evaluation of all these different measures. And the final impact of what they saw is that this is also, from an economical point of view, this is the cheapest solution. So it's cost effective at the same time. So more nurses might cost more, but at the same time, they give more quality and more productivity. And what you see is a cost effective measure. So we really need this kind of business case to show that more nurses, better working environment is better for recruitment, but at the same time is also cost effective. And I think these kind of cases are starting to grow now. So I hope that also COVID is a kind of situation that is really showing that this is unsustainable in the way we are working right now, and that we really have to change our healthcare system.
Okay, thank you. Absolutely agree, of course. So we have a question. When you spoke about data, so a question is, do you have an idea who could initiate an activity to collect more data on specialist nurses workforce?
Well, we could be many organizations. I think so. The first organizations I'm thinking of is the big organizations. Is OECD is doing that have some indicators. I think WHO is doing that. It might be European Commission. Of course, it's all limited to some countries, but I think it might also be done by some professional organizations. And I think that's what we can organize ourselves. So I think it would be worthwhile to know what is the situation in many countries and how many people we have available. At this moment in time, these data are available in some countries, not in other countries. It's not in a standardized way. I think it's still quite difficult. And I see that some data are really good, well available. but I see nursing data is still quite limited and quite scattered, in fact. Yeah.
Okay, thank you. Another question from the audience is, the problem of nurse shortage has existed the last 40 years. Do you think the COVID-19 will change this? And so yes, why?
Yeah, I think so. What nursing, what the COVID crisis is bringing us are a few interesting things. First interesting thing is what is essential for society, huh? And I think people want to do some things that are really essential, that makes lives better, that makes society better. I see also in some countries that recruitment levels are going up, and people want to be a nurse or a doctor because they want to save lives. They think this is a mission. This is something what you want to do in life. Huh? So there are some jobs that are more administrative and doing arranging things. And so people are saying, I don't want to do that. I see people moving careers from administration into nursing. Nursing is easier than become a doctor because they feel that they are missing some meaning in their life. So this is, I think, probably quite helpful. But at the other hand, I think it also will have some idea, give some other idea about how we think about budgets, how we think about healthcare systems. I think we didn't thought anymore about pandemics. So what I saw in many countries is that we are trying to measure everything and making our healthcare system lean. So it means no waste, very productive, high productivity, but so no reserve, no extras. We have to do every year. We have to do more with less. That's the main purpose of our healthcare system, to make it more industrial, more commercial, this kind of thing. What we learned now is that the pandemic is really saying you have to have a system that is also in place when something is happening very badly and worse. And we can have these pandemics in the future again. So I think that many governments, and that's what I feel in many countries, in many strategies, are really rethinking their strategy on healthcare. Yeah, and so it makes me a little bit more optimistic on that.
Okay, thank you. I think that we all need your optimism. So, another question, dear Walter, this was very interesting. My question is, if you are going to give this survey into a publication, so our colleagues are very interested in data.
I didn't thought about that, so yeah, we can discuss that. If you think it's useful, we can do that. Yeah, but so the idea was to just have this kind of talk, but it might be coming to a publication. Yeah, good suggestion.
Yes, but you give us also many points, main suggestions also to start research. Another question, why can't we work together for an European narration nurse patient that responds to quality and secure care?
Yeah, so the European nurse patient ratio, so this is of course the golden bullet. At this moment in time, there is no golden bullet. There is no evidence that there is one golden best ratio. So what we see is more nurses give better results, but it's very context related. And context means legislation. It also means what your hospital is doing. It's about the case mix of the hospital. It's about organization of the hospital. It's about legislation, what nurses are doing, what doctors are doing. It's so different from country to country. So it might be useful to give some advice. So I know that in the UK, NICE, and so the National Institute gives some recommendations for a nurse ratio. So that one nurse out for 8 patients. I know that some countries are using this recommendation. It's of course not an evidence recommendation, but it's an indication. So in Belgium, we are also starting to use this type of recommendation to say when you go above more patients per nurse, so it means above 1 out of 8, so it might be more dangerous, more risky, and you're creating more risks. So I think this kind of recommendations could help. So maybe we could do something in Europe for some types of units or type of patient wards. I know that the recommendation for ICU is much harder, so they have more consensus on that, and there's there's more evidence on intensive care.
But also maybe because in the intensive care units, the types of care are standard enough to set up some standards.
Yeah, I think it's more standardized as well. Yeah, absolutely. Yes. And the risk is high at the same time. So it's a high risk. So you have to really meet these standards. Otherwise, you're getting problems. And that's why I was so upset when I was reading what is happening in Germany in losing down these standards at this moment. So I was quite upset in reading that. Yeah.
Yes, and you also raised your concern on some strategies because you talk about also risks. For example, to increase the maximum working hours for nurses. I think this is, well, it's hard to define this strategy because it's very, very risky.
Yeah, it's absolutely risky, and I understand why they do that. So they need more nurses working in intensive care or for COVID patients. So if you don't have enough nurses, if they work more, then of course you have more resources available. So I understand the rationale, but of course, so when you're working 60 hours a week, you get more tired, and when you are more fatigued, and the risk of making an error much bigger, and at the same time it has some impact on your mental health and your personal well-being. So I think on short term it might be a helpful solution, but on the long term it's quite difficult to do. So
yes,
yeah.
Absolutely. And you raised the point also on restriction to visiting our families in hospitals. And I don't know if you did you heard some there were some comment in the past month about this restriction, because in many countries, and Italy as well, we really close the hospitals, not only of course for in the units with the COVID people, but also in the other unit, because of the risk to spread the virus everywhere. And there were some bad comment on these strategies, because we can understand that in many cases the people with COVID-19 admitted in the hospital, they died alone without the family around, and this is a real hot point to discuss.
Yeah, absolutely. Yeah. I see a change now in the second wave in many countries, that they are allowing one or two people. So it means a closed circle next to the patient, and I think it's reasonable to do that. I think one of the reasons they did that in the first wave is also because of the lack of protective equipment and masks and gloves and this kind of thing. So this is also a reason I think they did that in the first wave. But in the second wave, I think this reason is not valid anymore. So, but I agree. So it's really not good to keep these families out, because families have a very important role in taking care, and so patients feel really isolated and have some real mental issues. And so if you cannot talk with your family about your condition and are not seeing anybody, I think iPads are not helping.
Absolutely.
Yeah.
Yes.
So, but I see more and more countries now where the hospitals allow one or two people to come and visit in a very restrictive way. So that I think that's okay, but they should allow it. I think it's important.
I agree completely. Yes. And then there are some comments. There are a comment from Silvia from Italy that he works in Lombardy, and she commented the conditions are very hard, but everyone is committed. And then I'm reading some other comment on recommendation for personal protection equipment to protect nurses. So I think that we can close our webinar. So Walter, thank you once again very much to be here with us. And I thank you all the participants for joining us this afternoon in our EDTNA ERCA webinar. And I inform you that the recording of the webinar will be uploaded on our website in the next days. And also at the end of the webinar, a questionnaire will appear. So I kindly recommend to all participants to fill the questionnaire because your opinion really counts for us and in order, of course, to improve these webinars also in the next month. So I remember also that we will have a webinar once per month. So stay tuned with the EDTNA ERCA activities and please visit our website often so you can be updated for our news. So thank you, Walter, once again.
Thank you very much. My pleasure.
Yes, thank you. And take care, all of you. Stay safe, stay healthy. Bye-bye. Good afternoon.
Bye-bye.